Hey, how's everybody doing today? Hope you had a great weekend and you got an extra day off. Happy Labor Day to everybody. I had a little bit of a problem getting back into the swing of things as I came off vacation, but I was in the lab scanning last week and came across kind of an interesting case that highlights the importance of a careful clinical history. This is a venous study. Hope you enjoy. Yep, you know what day it is. It's Technical Tip Tuesday. So this was a 45-year-old female who was referred for particularly a venous insufficiency exam. She presented with a 2.5-month history of left leg edema. This was worked up by a duplex scan at another facility about 2 months ago, which was negative for DVT, according to the patient. Of note, she had a gastric banding procedure about 3 years ago and had experienced a 100-pound weight loss. She really changed her lifestyle. She exercises regularly, tells me she runs almost 30 minutes every day, and no other real pertinent risk factors. Interestingly, she also tells me that it's kind of funny. Sometimes she can run for 30 minutes without issue, and then other times becomes very short of breath upon walking even just a block. This episodic shortness of breath had been noted over the last 3 months. She also noted she had kind of a variable heart rate, sometimes fast, sometimes slow, she said. She had reported this to her physician at the time, who sent her for a cardiac workup, which apparently was largely negative. So here's her duplex scan. Her left common femoral vein, widely patent. It was easily compressible. A pretty phasic flow, a little bit of pulsatility, but that could actually be just proximity to the artery there. However, respiratory phasicity was easily appreciated. Here's her left femoral vein. We can see is widely patent. Again, kind of a phasic flow pattern through that as well. She was a little bit difficult to get good transverse compression images all the way down, so I won't bore you with those, but basically the entire femoral vein appeared to be widely patent. So when I'm taking a spectral analysis in the proximal left femoral vein, I'll always do a calf compression to check for augmentation up through the popliteal and the femoral vein, indirect evidence of patency. Now you have to be careful when doing that in the common femoral because you can augment through the profunda femoris, which can sometimes serve as a collateral or sometimes is just anatomically the dominant vessel. But in this person, look at that very, very minimal response to that vigorous calf compression. Almost no augmentation at all. The alarm should go off in your head. This is an obstruction. Now, we had a pretty good suspicion if we didn't already know it. Of course, the popliteal is obstructed. Transverse view on the left, longitudinal view on the right. That's actually the proximal extent of the thrombus. You can see the vein open up to the left of that longitudinal image. Now, in a case like this, I'm not going to do a whole lot of vigorous compressions. The diagnosis is made, showing that lack of compressibility is not really going to convince me one way or another. So be gentle on compressions in a case like this. Here's a little video clip of a longitudinal view. Again, and this is why I say be a little bit conservative on compressions. You don't want to necessarily dislodge that thrombus. The diagnosis is pretty much clearly made with this high quality image. So another short video clip of the popliteal vein in a transverse view. No doubt about it, thrombosed popliteal. So what we still need to do is make some judgment about the age of this thrombus. Now, we're really not that good at doing that with any kind of precision. If you look at the thrombus in this person, there does appear to be some hypoechoic areas as well as some subanechoic areas, suggestive of more acute process. One of the big things we do is use the onset of the patient's symptoms to help us. And so this one is kind of suspicious. Maybe it's been there for a while, but it also has an acute component to it as well. So our conclusion in this patient is certainly a deep vein thrombosis. This did extend from the calf veins, and I suspect she most likely had a DVT all along these many months. Of course, it probably started as an isolated calf vein thrombosis, and in fact, she has probably had small pulmonary emboli for all these many months. So part of our clinical history might be a question about shortness of breath in those patients that are referred to rule out a DVT. So, of course, I alerted the physician in the facility where I was scanning this patient, and given her history and findings, he suggested she should probably have a CT of the chest to see for sure whether or not she had pulmonary emboli. One of the sad things is actually I did my next patient and I was escorting them out. This lady was still in the hallway talking to her insurance company about getting authorization for the chest CT. I know this is a slide that I borrowed from a presentation a couple of weeks ago from when I was on vacation. I have a hard time getting my head back from the islands. Anyways, I hope you enjoyed this short presentation on clinical history, and I hope it kind of emphasized how important that can be in the care of your patients. You know what to do: like, subscribe, or if you need some extra Category 1 CME, please visit us at virtualveincenter.com. Thanks so much.